Dr. Morrow for the very thoughtful presentation. And now I would like to introduce our next speaker, Dr. Philip Poortmans, professor of radiation oncology at the University of Antwerp and Iridium Netwerk, and the former president of the European Society of Radiation and Oncology and the European Cancer Organization. Thank you, Dr. Poortmans, for being with us today.
Thank you very much for the kind introduction and also for the invitation for being here, notwithstanding all the restrictions that we face. So my topic is, can genomic risk be used to tailor radiation therapy? I will show you quite some data, but be reassured it's not a selection because there is not that much data. So it makes that I can give an overview of not all, you always miss something, but nearly everything there is. First, the slide with my disclosure is missing. I edited during the uploading, so my disclosure is that I'm medical advisor of Sordina intraoperative radiation therapy technologies. So let's start with the short introduction. The 20th century was for radiation oncology not alone, but for most of our treatments, one size fits all. So that means that in a patient population, in some of them, any treatment can be toxic and beneficial. There are ideal patients in the right lower corner where the treatment is not toxic and beneficial. But there are also where it is toxic and not beneficial, the red people, and then the yellow ones, not toxic and not beneficial. It doesn't serve, but it doesn't damage either. So we changed a lot, we learned a lot thanks to the work that has led to the classification of breast cancer, and nowadays proposed by many international guidelines is that we use 4 main subgroups of breast cancer: luminal A, luminal B, triple negative, and HER2 positive. And this has been extensively used mainly in systemic therapies. So the first attempts to do this in radiation oncology based on the molecular subtypes, one of the very first were the Danish. They used the data from their old trials run from 1982 still 1990, where patients with risk factors were randomized between yes or no post-mastectomy radiation therapy. They had ER, PR, and HER2 for 1,000 patients, and after mastectomy and partial axillary lymph node dissection, only 7 nodes removed. Patients who were premenopausal received CMF, postmenopausal was tamoxifen. Median follow-up was very long. What you can see for locoregional recurrence is that there was a benefit in all groups, but mainly in the luminal types. It was still present in the triple negative, but there was no benefit in the HER2 positive. And if you look at the translation into overall survival, that was present in the luminal types, but absolutely not existing in the HER2 positive and triple negative patients. So there it didn't contribute. Another study more recently published confirmed that luminal A after breast conserving therapy here had the lowest rates of local recurrence and distant metastasis. A meta-analysis after breast conserving therapy confirmed again the same, and that triple negative had the highest rate of local recurrence and distant metastasis. And then one after oncoplastic breast conserving therapy, more than 1,000 patients, similar, the luminal types have the lowest risk of recurrences, and the HER2 and triple negative, the highest one. This is, let's say, ancient history and the start of all of it. Now we're really working in the molecular subtypes. And what we did is, for example, using the HERA trial, where we looked into HER2 positive patients who did receive trastuzumab and had a mastectomy, whether or not post-mastectomy radiation therapy contributed in those who had 1 to 3 positive nodes. And what we saw was that the magnitude of benefit was lower than historic studies, but higher than in the Danish study, where there was absolutely no benefit. The same for the Beatrice trial in triple negative patients with modern systemic therapy. The benefit is lower than in some historical reports, but much higher than in the old Danish studies. We also looked at the boost in the HERA trial for the patients that received trastuzumab, and the boost had no significant benefit in those patients at 11 years of follow-up. Another study, primary systemic therapy with breast-conserving follow-up 7 years, higher local recurrence risk for patients who had either HER2 positive treated without trastuzumab and triple negative who did not have a pathological complete response. And then a smaller study about 233 patients, primary systemic therapy, mastectomy, post-mastectomy radiation therapy, no recurrences in triple negatives who had a pathological complete response, intermediate in the hormonal receptor positive and the HER2 positive, but a very high rate of recurrences in the patients, locoregional recurrences in the patients who had a triple negative cancer without a good response to the chemotherapy. The next step, of course, is to go to the genomic signatures. The best known is from Thierry Mamounas, who used old data. They are 30 years old, nearly, let's say 25 years old, more than 1,000 patients, ER positive, tamoxifen treated, and they had no post-mastectomy radiation therapy, follow-up longer than 11 years. And what he found was that the 21 gene recurrence score indeed predicted locoregional recurrences in these patients. So you can see that the high score patients had the highest risk of recurrences, the intermediate score, intermediate, and the lowest had the lowest score. And this was confirmed in patients both who had 1 to 3 nodes or 4 and more nodes, where the absolute risks were, of course, higher in the 4 nodes and more. So it could predict in patients who had treated with endocrine therapy and who had a mastectomy without radiation therapy, which patients benefited possibly more from post-mastectomy radiation therapy. Other studies, very short, from Winnie Woodward, also with the 21 gene recurrence score using the SWOG data, also about 30 years out, 3 years old, 11 years of follow-up, very similar. Low recurrence score, less than 10%, intermediate and high, 16.5. EndoPredict, FITSAL, showed in more than 1,300 patients postmenopausal who received tamoxifen and were randomized to yes or no longer treatment with an aromatase inhibitor, median follow-up 6 years, that the patients who had a high risk score had a higher risk of recurrences, 9% compared to the low risk score, only 2.5%. Breast-conserving therapy was identical to mastectomy, and patients who had a low-risk score and breast-conserving therapy fared much better than the patients who had no radiation therapy in case of a low-risk score. He also did this exercise using PAM50, and there he did not find a predictive effect for the benefit of radiation therapy, but a score below or above 57 had some clue to the risk of 5-year local recurrences. Mind here that most of the patients received radiation therapy. Then the radiosensitivity gene expression, 300 patients, breast-conserving therapy with or without radiation therapy, long follow-up, patients who were ER positive and received radiation therapy, the low-risk patients did good, the high-risk patients had many more recurrences. ER positive without radiation therapy, similar difference, but higher risks of recurrence, but especially the patients with ER negative with a high risk score had a huge risk for recurrences, although in the low risk score they didn't have. The ARTIC is adjuvant radiotherapy intensification classifier, 27 genes combined with age, used in a trial in Sweden in the 90s. They had material for more than 700 patients. After PN0, they were randomized to breast-conserving therapy with or without radiation therapy, long follow-up, low score, clear difference between no radiation therapy and yes radiation therapy, although the difference for the score was much less in those who had a high ARTIC score. In the radiation therapy arm, ARTIC predicted the risk of recurrences much better than in the no radiation therapy arm. What are the ongoing trials in low-risk patients? They use several identifiers. Some use just the classical ERPR HER2, but others also use PAM50 or Oncotype-DX to select the patients for omitting of radiation therapy, or, like in my personal favorite, of course, the Europa trial, where luminal A early stage patients above 70 will be randomized between only partial breast irradiation or only endocrine therapy during 5 years. Also in DCIS, there is some data. The ECOG study with 327 patients that had material without radiation therapy, fairly long follow-up. The score, the Oncotype-DX DCIS score, quantified the risk for invasive ipsilateral breast events and total, but not for DCIS events. It complemented clinical and pathological factors. In this, please do mind, they only included very early stage and low risk patients. The higher risk patients needed to have very small tumors. This was later on used to compare with the DCIS nomogram, and the conclusion there in only 59 patients was that it was not warranted in this study with these criteria. The decision score, decision RT, was first tested and then validated. And also here, it is a prognostic score for the risk of local recurrences, but again, only in invasive breast events and in total breast events. And it predicts the radiation therapy benefit. Then one of my favorites is GARD. GARD is genomic-based adjusted radiation therapy dose. And in 2017, they published their first tests, their first model. It's a clinical model where genomic data are used to individualize the radiation dose. They did this not only for breast cancer, but in 20 primary solid tumors. And they tested whether it was a predictor for clinical outcome. For that, they used 5 independent clinical data sets. And based on that, they made a prediction model to check what the impact is of an increasing radiation therapy dose on control, so that you can individualize your prescription to the individualized tumor. So this was an interesting framework where you can see that patients overall, distant metastasis-free survival, this is a breast cohort, that the low GARD scores have a much higher risk for distant metastasis compared to the high risk score. This was the Erasmus breast cancer cohort. There was a second breast cancer cohort, Karolinska, which was identical. And in the multivariate model, only the GARD remained as a significant factor. So based on that, we wrote a very hope-giving title as a comment that we might, helped by GARD, enter the era of individualized medicine. And recently, 2021, they published their validation studies. And the validation studies are very exciting in 11 cancer cohorts, including breast cancer, but not exclusively. And it indeed predicts in those cohorts the benefits of radiation therapy by quantifying the relative benefit of radiation therapy for each individual patient. And here it outperforms the pure radiation therapy dose, both in terms of recurrence, but also in survival figures. So this might help us to individually predict the benefit per patient. It's not homogeneous, so it can differ within cohorts, within patient groups. It really goes to every individual patient. So this paradigm should be tested in further clinical trials, prospective clinical trials, to check whether we can taper off or increase the radiation dose depending on the risks. Also here we had the chance to write a comment, and this is for the non-radiation oncologist the typical dose response curve for tumor control probability, that's here, and the normal tissue complication probability, that is here. So you have a therapeutic window where you can cure the tumor without complications. But this is 100 patients mixed together. If we go to individual patients, you have individual patients where both the tumor and the normal tissues are very sensitive to radiation. You have others where they're very resistant to radiation. This would, for me, be a typical glioblastoma tumor, a high-grade brain tumor. And then some patients, the lucky ones, they have a good sensitivity for the tumor and a higher resistance for the normal tissue. So these models need to be prospectively worked out. Then there is some varia. For example, Bartlett and his group compared several of those tests in the Optima Prelim trial. And what they found is that, in fact, all of those tests works. They used Oncotype-DX to start from, to select the treatment for the patients, and they used several others in this work and divided it by Blueprint, Mammotyper, and Procinia. But basically, it was equivalent for the population as a whole. But for the individual patient, the test might provide different outcomes. Then a radiation-induced gene signature to predict for pathological complete response to primary systemic therapy in breast cancer patients, because in fact the cellular response mechanisms are quite similar for radiation therapy as they are for chemotherapy. So the radiation response genes might be used to predict response to chemotherapy. They worked with murine null breast cancer cell lines, P53 null lines, and they used this as to test as a predictor for PCR and validated it on 2 independent data sets and trained it thereafter on 337 human breast cancer cell lines. So they ended up with 30 genes that were predictive for survival. And the mean expression is predictive for PCR. So this could, again, be a way to explore in future trials using radiotherapy signature to predict effect to chemotherapy. The radiation response signature is predictive of the timing of recurrence, whether you have an early recurrence, in general it's taken 3 years, like in this study, or after 3 years. Breast-conserving therapy with radiation therapy, training cohort 119 patients and 16 in the validation cohort of the total of a larger group, of course. And of the 485 genes they started with, they retained 41. And it indeed can identify patients that are unlikely to respond to postoperative radiation therapy and have a very early recurrence. Thereby, by predicting the timing of recurrences, it might help selecting patients for intensifying treatment. A molecular signature to test the response to preoperative radiation therapy, tested in locally advanced breast cancer, of course, 134 patients, most had systemic therapy, and it was afterwards validated in another group of 60 locally advanced breast cancer patients in the postoperative setting. So the conclusions were that if surgery and radiation therapy was given, that there was a clear discrimination based on this gene expression. While patients who had only surgery, there was no discrimination, no difference. And MAP3K4 could be a biomarker of response. We heard that earlier during this Congress. And then I will go a little bit more in detail for this, as I have been involved. It's the Young Boost trial. We did not yet publish the primary results, which is local recurrence in young patients below 50 years. We included in this trial 2,421 patients, one quarter of them below 40, 3/4 between 41 and 50, and we randomized them between a standard and a high boost dose after whole breast irradiation. And for every recurrent case, we matched 3 controls, and we checked for clinical pathological factors, but also for copy number and gene expression profiles, cases versus controls, and the primary tumor versus the local recurrence. And now you see why we cannot publish our primary outcomes. We have a follow-up of about 10 years, and the local recurrence rate is 2.56% in those patients who are considered as having a risk for local recurrences. So that means that how will we ever be able to demonstrate the difference between a standard boost dose and a high boost dose? Now, the message is already clear. We will not need a high boost dose, but we can learn a lot about which patients recur. So what are the pathological features that are predictive for the recurrent tumors? Those who recur, it's ER, it's PR, it's Ki-67, it's a basal subtype, but all other factors did not matter for predicting local recurrence, so comparing the controls. And this is more to show you that also in radiation oncology, we can do clustering of gene expression data. This is for groups based on a subtype using PAM50, and this on DNA copy. And then the supervised clustering with the heat maps. The conclusions are that the local recurrence rate is very low, that the tumors that recur are the same as the initial tumors, it are not new primary. This was confirmed with copy number and gene expression profiles. The basal subtype is the highest risk factor for local recurrence. The cases had more gains of FR1 and IGF-1R, and the controls had more gains of CCND1. And there was an upregulation in the P53 pathway in recurrent tumor. So it are not new primaries, and we could unfortunately not define a genomic classifier for local recurrences. So coming to my discussion, most of you have seen me presenting this before. It's the interaction between systemic and local regional treatments that I want to explain. Here you see the decreasing risk for distant metastasis, as well as the increasing effectiveness of systemic therapy. And this is the benefit of surgery and radiation therapy on overall survival. In the old EBC-TCG meta-analysis, you could see that the high-risk patients that did not receive effective systemic therapy had no benefit from, for example, post-mastectomy radiation therapy. In the 2005 paper came the famous, for every 4 local recurrences prevented at 5 years, there was 1 breast cancer death less at 10 years. And in the subsequent papers, it was even more favorable. But we also know that there are very low risk patients or patients who receive extremely high effective systemic therapy, where the benefit of radiation therapy in this case will be less. So we can decrease local treatment, or in the low risk patients, we might also decrease the systemic therapy. So if we go to the triple negative breast cancer that have a PCR and a HER2 type, in the study of the Danish, no benefit from radiation therapy. Then it increased with better treatments, more effective systemic therapy, but it made a big jump after the introduction of trastuzumab. And now, like in the HERO trial, we are over the top of the effect of post-mastectomy radiation therapy, and we have to explore further which patients will have even less benefit. Then the triple negative that do not obtain a PCR or the luminal B, we didn't change a lot over the last 20, 30 years. Very sorry for those patients. The same for luminal A and some others in a very early stage. Little changed, but they already fare extremely well. And then especially the luminal A with a low risk if they do not receive endocrine therapy, like for example on a country base in the Netherlands, they will benefit more from radiation therapy than the patients who receive standard endocrine therapy like in most other countries. So tailoring radiation therapy is about selecting target volumes, breast, chest wall, and all the components of the lymph nodes. It's about the size, whole breast versus partial breast. But after mastectomy, what's often forgotten is that the target volume should be much smaller than the initial breast, because you remove part of the target volume, being the resected skin with the underlying draining lymphatics. And please boost only when needed, because we see much less recurrences. In the 80s, at 10 years, we had 20% recurrences after breast-conserving therapy. In the 90s, early 2000, it was 10%, and now we are at, as I showed, 2.57% in young patients. This study, the IMPORT-LOW study, also shows that lowering a little bit the dose remotely from the tumor already decreases side effects. So we need to learn how we can taper off our dose when we increase the distance to the primary tumor. So concluding, most data on genomic risk tailoring for radiation therapy are based on metastatic disease and on systemic therapy. The tailoring of surgery and radiation up to now concerns more which target volumes and how intensive to treat it. And often combining several treatments together is better, is less toxic than giving a lot of one treatment and omitting the other. The relation between the risk factors, predictive and prognostic factors, and the benefit of radiation therapy are influenced by tumor stage and interaction with systemic therapy. And this varies a lot over time. And it is a multidisciplinary approach. Treatments can be mutually interchangeable. Dose escalation should go step by step, and we need to take into account several endpoints. So unfortunately, my conclusion is that we don't have validated biomarkers that, as of today, can predict the benefit derived from radiation therapy to the individual patient level. So we need to continue. When we have much less, we are a little bit a victim of our success. We see very little locoregional recurrences with current treatment paradigms. And I also think that local and even more regional recurrences are not the optimal endpoint. We have to think about any recurrence, overall survival, and even more quality of life. And then we will go to individualized treatments. So improving the fate of the patient, taking into account the tumor, the patient as a body, the other treatments, and of course, informed consent and shared decision-making. And that way, we can obtain the best outcomes to tailor-made solutions. These are the people I would like to thank. And with this, I thank you all for your presence.